So our speaker today is Dr. Matthew Weiss, and Dr. Weiss is going to be talking today about organ donation after medical assistance in dying, focusing on the ethical and legal concerns.
Yeah, thanks so much, Karen, and thanks for everybody on the line for being here. And also, this might be a little bit, there are a few slides, might be a little disconcerting for people. It's something that happens a lot when working in a Francophone center where people present in one language, but their slides are in another. And some of this talk I've given more often in French than English, and so some of the slides will have some French terms on them, but don't worry, I'll explain for the non-Francophones in the audience. So yeah, as mentioned, we're going to focus on the ethical and legal concerns of MAID in relation to donation after MAID. And just before I get started, these are my affiliations. So I don't have any conflicts of interest with any commercial entities. I have been remunerated as a consultant both with CBS and Transplant Quebec. I'm a full-time pediatric intensivist, and I'm a researcher with interest in the field, obviously. So just as you see definitions as we go through, MAID or AMM, so that's medical assistance in dying, or the French term, which is aide médicale à mourir. So if you see that abbreviation, that's what it means. DDC is the same as DCD, which is donation after circulatory death in English, or don après décès circulatoire. And then DDN is the same as NDD, or neurologic termination of death. So just to give credit to some of my colleagues, this is a great paper that just recently came out in the McGill Journal of Law and Health by Sherry, Jen, and Linda and Daniel. Really examining a lot of the medical and legal the legal and ethical issues around this topic. Great read. It seems like a long paper, but it reads quickly. So I would highly recommend it if anybody wants to look up other information after this talk. So the key points for this talk. First of all, just to let people know that donation after medical assistance in dying is already part of the Canadian donation system, and donation and transplantation organizations have no role in MAID decisions. If you take anything away, it's that really we as the donation professionals are not going to are going to be completely divorced from the MAID decisions, and so those are some key points to take home. So I know we have lots of trainees on the call, and maybe some people who aren't as familiar with donation after circulatory death versus donation after neurologic determination of death. So just wanted to put this slide up to make sure we know what we're talking about, especially in the concept of MAID. So MAID, obviously, it is an elective procedure from awake and competent patients, and so that is going to follow the donation after circulatory death pathway. Now, the classic DCD pathway you can see here, it usually starts with a patient who has had a significant injury or illness, most often a neurologic injury, and the family has agreed to withdraw life-sustaining therapy. And so after that decision is made, you have identification, referral, consent process, withdrawal of therapy, death determination, and then organ recovery, with donor care and family care taking place throughout the entire process. Now that paradigm changes some in the context of a DCD, just in the sense that there isn't really this stage here with withdrawal therapy. What you have here is, this is the process of DCD after, again, aide médicale à mourir, or MAID, and this is prélèvement des organes, organ recovery. So what's going to happen here in this process is, so this is where the medication that is going to be given for medical assistance in dying, and we're going to talk about some of the aspects of that later in the talk. We talk about MAID. That drug cocktail is given, and then it's going to quickly proceed to death. Now that's as opposed to in a typical DCD scenario where you don't really know how long it's going to take between when you do withdrawal of therapy, which is typically you're talking about extubation or removing the patient from the ventilator, until you can determine death. And so some of those patients might take only 2 minutes before they pass away and are determined dead. Others, it might take 60 minutes, 120 minutes, and it might even be outside the window where organ recovery is possible, because during that time there's progressive hypoxia and organ dysfunction. Now, in a MAID scenario, what you have is you know that the drug cocktail is going to be given, you know that there's going to be a rapid death, and then you know that the period of time after death determination to clampage or into flush of solution to preserve the organs is also going to be rapid. So this here, where it says ischemia showed, that's the warm ischemic time. That warm ischemic time is going to be limited in a MAID situation, and also just so people understand, actually I'll mention it here, the difference between this and a typical MAID procedure is the fundamental difference is that it's going to happen in a hospital setting. Often MAID, as it is practiced today, sometimes it's done in a hospital, but often it's done at home, at the patient's home. And so if a patient who is going to pursue medical assistance in dying is motivated to also pursue organ donation, well, they're going to have to accept that the process will happen in a hospital where the medicines for MAID will be administered and the patient will be quickly transported to the operating theater, or the whole procedure will take place in the operating theater to avoid ischemic injury to the organs. And this just shows some differences between typical DCD versus DCD with MAID. So here the consent for DCD is done by the family, because most of the time you're talking about a patient who has had a significant injury and is already in the ICU and unable to give consent for him or herself. Whereas in DCD with MAID, well, it's the patient, him or herself, who's giving the consent. For the evaluation before the transplant, well, the interview is done in DCD with the family, but in MAID it's done with the patient, and that actually has some implications for the healthcare workers. They're often sometimes less at ease to have that conversation with the patient themselves. Also, for DCD, for any exams or medical testing that's done prior to the donation process, well, that's all done for a patient who's already in the ICU. So arranging a abdominal ultrasound, for example, is quite easy. Patient's already there. In a patient who is being treated and followed at home, who's organizing an elective MAID process, well, that patient is probably going to need to be transferred to the hospital. You don't want to do a bunch of painful procedures to these people if we can avoid it, who are conscious and competent, and we want to make sure that we group those testings in a way that is the most convenient for them. These are often people who have significant handicaps and often a significant amount of pain in their daily lives, so even just getting to the hospital is sometimes a big challenge. And then here, this last box is withdrawal of therapy. So in DCD, there is withdrawal. In DCD with MAID, it's the administration of the meds, as I mentioned before. So anytime you're going to consider this, I think it's not the primary focus is not of MAID is to offer the opportunity to pursue organ donation for patients who are already undergoing MAID. And if they are interested in MAID, we want to make sure that they happen to also be interested in organ donation. We want to make sure that that process is a reality, or is something we can offer. There's also the question, though, is this feasible? And if it's feasible, what is the impact, the potential impact of donation after MAID on the system? And so, to put it in context, that's something of a difficult question to answer, because there are only currently 3 countries in the world, you can see them here, they're in red, Belgium, Canada, and Holland, where donation after MAID is a possibility. You have to have a country that obviously authorizes medical assistance in dying, or euthanasia as it's called, and sometimes in other countries, and then combine that with a system where organ donation, with a well-functioning organ donation system. So this is a new procedure. You can see this is from the I forget which city in Holland, but this is from the group out of Holland, published in 2011, where they had already done some lungs after medical assistance in dying, and you can see they've reported on that. If you look at MAID in the province of Quebec, you can see that the numbers happen all through different areas of the province. If you add them up, over the last in 2015 to 16, there were 461 patients. if you look at those numbers over the last couple of years, you can see a sharp increase from 2016 to 2017, and even a 6-month to 6-month increase within the year of 2017, where the numbers continue to rise. And that's significant because if you want to know whether there is a pool of potential donors, well, you need to know how many MAID cases are happening, but then you also need to understand why. So if you look on this chart, this is looking at the causes of the primary diagnoses of people who are requesting MAID. And this column here in Canada from 2017, so you talk about these are the percentages of the different diagnoses. So here neoplasm is obviously the most frequent, 57%. But if you look here, neurologic condition was about 25% of conditions throughout, of requesters throughout Canada. So that included things like ALS or Lou Gehrig's disease, advanced Parkinson's, these neurodegenerative diseases that are not contraindications to donation. And if you look only at that group, even excluding underlying cardiorespiratory problems, you can consider that if in the province of Quebec, I kind of did a back-of-the-envelope calculation, we're lining up for about 750 MAID cases a year. Whether it will be more or less, I suspect it will be more annually coming forward. But if about 25% of those are neurodegenerative patients, well, that leaves about 190 potential donors from that diagnostic category. If you assume that maybe 50% of them would be medically ineligible for other reasons, so for example, one of our potential MAID donors in Quebec was they discovered a melanoma, a remote history of melanoma, and he became ineligible because of that. So if you conservatively estimate that half of them would be ineligible for organ donation for other reasons, that still leaves about 95 potential donors. And the consent rate is very difficult to estimate. It's unknown what the consent rate would be. But if you figure 30% consent rate, which is half of a typical consent rate for organ donation, that still leaves you with about 25 potential donors per year. And if that were the case, that would represent a 14% increase in donation in the province of Quebec, and those numbers would roughly be similar in Ontario in terms of the impact on the donation system. So you can see it's a non-negligible source of organs, and something that would be feasible considering the types of diagnoses that are leading to people asking for MAID. So. So in response to the first question, it does seem to be feasible from a system perspective. But then the questions become, well, what are the legal and ethical issues that might be in play? And so if you look at just MAID by itself, the legal framework that governs MAID, I think it's a good idea to have an understanding of that. So the time frame, and I think I'll take the time to thank Fred Darragon. I don't know if he's on this call, but he put together some of these slides. We kind of share them throughout Transplant Quebec, so he put together several of these slides I've been showing. So in 2014, in June, Quebec passed their Death with Dignity law that was set to be enacted in late 2015 that did authorize MAID as part of that legislation. In the meantime, in early 2015, there was the Carter case, which you are probably familiar with, which was the case that required the federal government to organize to allow medical assistance in dying, ruling that forcing patients to pursue suicide unassisted by medical help was against their basic human rights. And in 2016, in June, the federal MAID law was passed. So MAID is a legal option throughout Canada for people with intractable suffering and a terminal prognosis. And I'm not going to really take the time to get into the differences here between the consent and federal law. There are subtle differences. But here in Quebec, what you're talking about is greater than 18 years old and apt or competent to give consent. And that's an important point. All up until the end, up until the administration of the MAID drug cocktail, the patients need to remain competent. And so if you had a patient who has, because of a progression of the underlying disease, loses their ability to give final consent, they would no longer be eligible for MAID. And that's important for organ donation, as we'll talk about shortly. They need to have a terminal prognosis that is incurable, and it needs to be advanced and irreversible, and they need to, according to the Quebec law, constant and intolerable suffering. So the other considerations that I have in importance towards organ donation is that and this is true in Quebec and true throughout Canada, that any administration of MAID needs to be done through administering medicines. So it needs to be done, it's a medical dying, and that precludes something we're going to talk about later, which is death by donation, and I'll mention why when we get there. It has to be at the patient has to ask for it, à sa demande, as it says here, by the patient, by a person who is at the end of their life, with the goal of relieving their suffering. And it also stated in the Quebec Death with Dignity law that MAID itself should be an exceptional intervention. That this should not be something. This should not be a first-line therapy, obviously, but only for people that we've tried other avenues of palliative care and it doesn't work, and there's no possibility for it to work. This is from the Radio Canada, so you can see Aid Medica, AMM, or MAID, and organ donation, ethical questions that have been brought up from this. And this is just from October of last year. So you can see that this is a question that is being brought up by patients, by healthcare workers, and by the media. And that's why organizations such as Transplant Quebec, Trillium in Ontario, Canadian Blood Services have all been working to try to develop recommendations around how to create an ethical structure of practicing organ donation after MAID. So with that in mind, I want to talk about what are the ethical issues. And so as I mentioned, that paper by Jen Chandler and her colleagues really touches on a lot of this, but these are a lot of things that were analyzed by a CBS consensus meeting that happened last year. Unfortunately, I wasn't able to attend that meeting, but and that report is being finalized, but it really touches on a lot. And so a lot of the things that I'm going to be discussing were addressed in that meeting and the upcoming report. So the potential issues, there are other issues that could potentially be in play when you are considering whether organ donation after MAID is an ethical practice. But these are some potential issues that need to be addressed. And one is the capacity for consent. The second one is probably the one that has received the most attention, at least here in Quebec, lack of coercion or solicitation, and balancing that lack of coercion against the patient autonomy and non-discrimination, respect to the dead donor rule, and then protection from conflicts of interest. So I'm going to take those one at a time. The consent capacity in some ways is the easiest, considering, as I just showed, in MAID legislation in Canada, the patient needs to be competent to give free, informed consent right up to the end. And so for most people that examine this question, well, if the patient is competent enough to pursue MAID, they're competent enough to give their consent for organ donation. There's broad agreement on that issue. There are some more subtle questions that have come up around MAID. So, for example, how much can or should medical professionals ask for? So, as I mentioned, if a patient who wants to pursue both MAID and organ donation, they're going to need to do that in the hospital. And I think, considering they can give free consent, most people would agree that if an autonomous patient can choose whether it is more important for him or her to die in the hospital, to die at home, versus pursue organ donation. But we have to understand that because of the way the system is built, we're placing the patients in a situation where they have to make a choice. And I think people start to get less and less comfortable depending on how invasive the procedures are. So, for example, you could imagine a system where the patients are asked to permit the placement of large bore catheters into their femoral veins or arteries before they're dead, and is that a reasonable thing to ask of them, or is it reasonable for them to submit to drugs before their death that might immunosuppress them and facilitate organ transplantation? And so I think there are some questions around what are reasonable interventions. There's no universally accepted standard, and I think it's something that we're going to have to talk about as MAID becomes more implanted in the system, or donation after MAID becomes more implanted. And then on the flip side, how much can we approve? So how is the system going to deal with a patient who, let's say, who might have a lot of knowledge? Let's say it's someone who has worked in an ICU and says, look, I want those large bore catheters placed in me to make sure that my organs are flushed immediately after I'm dead. And when is that consent considered valid, and how much suffering do we allow these people to undergo, if any, prior to donation? So I think those two are things that have not been complete, because this is such a new practice. We haven't hit upon the answer to all of that, but it's definitely something we need to think about. As I mentioned, so there's this idea of solicitation, and I'm gonna kind of talk through this as we go forward. And before I put these reports up, if you were to imagine that same continuum, but instead of having the dates to the left and right, if you had on the left a system where the patient had to come forward and ask him or herself for the option for donation, but healthcare workers never mentioned it proactively to a patient who is undergoing MAID. That's one option. What's one end of the continuum. And if on the other end of the continuum you had a system, and this is I'm mentioning this as a hypothetical system that would never exist, but a system that actively was coercing people to pursue medical assistance in dying in order to increase organ donation, well, obviously that system on the right no one would be comfortable with. That would be coercion. And there's kind of a continuum between a system that never asks and a coercive system where people have been very concerned around ideas of solicitation. So for instance, a system where after a patient has agreed to MAID, a representative could conceivably come in and tell them about the benefits of organ donation and try to sell them on organ donation. Now, obviously, that would be solicitation. And once again, that would be a system that just about everyone in North America would be pretty uncomfortable with. Now, in Quebec, there were two opinions that have been issued around around donation after MAID in general, but really where they diverged the most was on the question of solicitation and or informing patients. So on April 19th in 2016, the Transplant Quebec Ethics Committee issued a report that was quite conservative. Transplant Quebec had a lot of concern that they wanted in no way for the public to think that Transplant Quebec was associated with or wanted to increase MAID activity in order to have more organ donation. And so their recommendation was essentially that we should not inform patients and to only accept donation in a circumstance where the patient, him or herself, had brought it up prior to any mention by a healthcare worker. Now, at the same time, there's the Commission de l'éthique en sciences et technologies. This is a government board that looks at different ethical issues, obviously around science and technology, who issued a report just about less than a month later with similar findings globally, saying that donation after MAID is acceptable, but they were actually less conservative or less around the issue of informing. So they obviously were against coercion or solicitation, but they didn't see any ethical contraindication to informing patients that donation might be a possibility. And so that's here it says a lot of that same information. And if you look around the rest of the country, well, in Ontario, they mentioned that patients should be approached for donation as in any imminent death, and that's based on their interpretation of the law in Ontario, which requires approaching families if the death is imminent to at least discuss the possibility of organ donation. So they applied that same reasoning here, even though the law was not written with MAID in mind, which is the same case, which is also the case in Quebec, and we are at Transplant Quebec currently undergoing a period of reflection as to whether we think that MAID qualifies as this kind of imminent death. It clearly was not in the minds of the legislators when they wrote the statute, but you could also very reasonably argue, well, this is a planned imminent death, and we should be approaching these patients. So we're currently at Transplant Quebec revising our position, and I can say that there's a provisional change that has been accepted by most of the committees at Transplant Quebec, but it has not had final approval. That will recommend that treating physicians can or should inform the patient of possible donation once the decision for MAID has been finalized. Now, once again, it's important to just re-mention that we don't have any contact with these patients during the decision process of evaluation for MAID, either determining whether they're eligible or determining whether MAID is a good option for an individual patient. So really it's going to be up to the treating physicians, the family docs, the palliative care docs, the internal medicine guys who are administering MAID and planning MAID to mention to the patients that this might be a possibility, at which point they would identify and refer to Transplant Quebec for more information. Obviously, there's a sharp distinction between that and solicitation and or coercion, and really a lot of the decision making around this with the Transplant Quebec Ethics Committee were around principles of equity and autonomy. Equity is an important one because if you believe that organ donation can bring benefit to either the patient who's a potential organ donor, to know that they are going to have a part of them help someone else through donation, or if you believe that it could help decrease the intensity of the bereavement or grief for the families after the loss of their loved one. Well, if you believe that those benefits exist, then to deny a patient the potential of those benefits simply because they're going through the MAID process seemed discriminatory to the ethics committee, and the more we think about this, the more that becomes a clear line of reasoning. And so the idea is to instead, obviously, not put pressure on patients to pursue something they would not want to do, but to give them the opportunity to autonomously decide whether or not they want to pursue organ donation according to their own belief system. So that was really, and it also says, yes, it also acknowledges that, yes, there is potential for healthcare workers to place pressure on people, but it assumes that the patient is going to be an autonomous actor who's going to be able to simply say, no, I'm not interested in organ donation, I'm not interested in learning more, or even later in the process withdrawing their consent, because as we mentioned, they need to be competent throughout the entire process. So that was the evolution around thinking here in Quebec, and while I'd like to just reemphasize that while that change is not finalized yet, it seems to be imminent. And it also in line with the Ontario process. And Ontario has been under this regime of mandatory information of all MAID patients for a while. So one of the other issues is respect for the dead donor rule. And I guess for those of you who might not be familiar with the dead donor rule, just a quick note, just as I'm sure you all recognize King Chapel from the Cornell College campus in Mount Vernon, Iowa, where I went to undergrad, there's the cornerstone of King Chapel. Well, the dead donor rule is really one of the cornerstones of the ethics of donation, and it simply states that organ donors must be dead before procurement of organs begins, and that organ procurement itself must not cause the death of the donor. Oh, sorry for the typo there. that is, a basic principle of ethics, and it's the law throughout North America. So any time that you talk about donation after MAID, well, you need to make sure that those patients are dead, which is why I went through the process of DCD at the beginning of the talk. It needs to respect that DCD process, and in doing so, there needs to be strict adherence to an objective and clear criteria of confirmation of death, because DCD depends on an absence of circulation. And so in a routine DCD setting, what is generally used is an arterial line, which is it's the same size as an IV, but it's placed into an artery so that you can watch the blood pressure, and when you lose pulsatility of the blood pressure, the patient is confirmed to be dead. Well, in general, DCD patients or DCD eligible patients will already have that in place. And most people would accept that if they did not have it, placing one for donation is acceptable. In a MAID situation, it's a little more tricky. While arterial lines, or ART lines as we call them, are routine procedures, they're not without potential pain. And even though we do a lot of them, sometimes they can be difficult. In certain patient populations, they can even be more so if there's arteriosclerosis or even some of the neurodegenerative diseases. The arteries move a little more and they're harder to get a line in. So this gets back to that question of what should we ask of the patients. Is asking of installation of an arterial line appropriate? Is requiring it appropriate? If we don't use an arterial line, what are the other options we're going to use? Well, using an echo is another option. You could use real-time echocardiography and watch the aortic valve, and when it stops to open, you have confirmation of absence of circulation. It's not without while it's less invasive or painful, it does require the exposure of an echo window, so that part of the patient's chest will be exposed. It requires another machine to be present at the time of death. You'd have to find someone who can interpret it. So there are some disadvantages there. Otherwise, you could also look at an ECG. And when there is absence of ECG tracing, you are assured that there's absence of circulation. The problem is sometimes, or certainly in a standard DCD process, we know that electrical activity can continue on after the circulation has stopped. We don't really know in a MAID setting if that is true. Considering the cocktail of drugs that's given, it's entirely possible that circulation and ECG activity would stop a lot quicker, but we don't know that. And so these are both scientific and ethical questions around MAID that will need to be refined as we could become more familiar with the process. The other thing that comes up with the dead donor rule when people talk about death by MAID is the concept of death by donation. Now, as I mentioned, the dead donor rule is pretty clear on this. Donation cannot cause death. So the legal concept is currently settled. This is something that cannot happen in Canada. But ethically, there are people who raise the question, well, if we are going to be causing death by injection of a medicine, well, ethically speaking, what's the difference between that and taking a patient to the operating room, putting them under general anesthesia, and removing their heart while it is still beating, and having an organ donation process that more closely resembles an organ donation after neurologic determination of death with no warm ischemic time? And ethically, there are a lot of there are a lot of people who would argue there's very little difference. But just to be clear, that would require a change in law and a change in practice in Canada before it could be something that could be considered. But it's something that I think already we've had patients push back on that concept and ask, why is that the case? Why is the law like this? So I think, as I've mentioned it several times throughout this presentation, this particular type of donation after MAID, brings up several questions around the fundamental ethics and legality of the donation system. There are also conflicts of interest. So here I've already mentioned that the transplant, and here I say transplant could be Trillium, it could be the individual transplant program. no member of that team should have any role in the AMM decision or death determination, which realistically that's quite similar to any other donation situation. So, for example, those same actors should have no role in the decision to withdraw life-sustaining therapy in a potential DCD situation. But there just needs to be a clear, bright line that is reinforced in the setting of MAID. And also, both the upcoming Transplant Quebec recommendations, anything that you read on this the topic will reinforce that there should be no healthcare professional-initiated discussion of donation prior to the final MAID decision. So you wouldn't want to even give the impression that you are encouraging the MAID decision by the possibility of organ donation. Now, obviously, in the case of a patient-initiated discussion, that can you can acknowledge that donation may or may not be a possibility depending on the situation of the patient. But as we would in a routine DCD discussion before the finalization of the withdrawal decision, we'd recommend telling the patient telling the patient that might happen, but we'll need to discuss it after we finalize the MAID discussion. That's the real that needs to be finalized first, and then we can move on to the possibility of donation. So practice in Quebec to date, I'm sorry I don't have Ontario numbers to talk about. I know they've done a few more cases than us, but we're still talking about, in the ballpark of 10 to 15. As of now, there have been 5 potential donors that we've evaluated. You've had 3 ALS, one that was a IMPUC. It was sorry, I'm blanking on the translation. A COPD exacerbation, and another that was a Parkinson patient. And of those, 3 were canceled, and 2 became actual donors. You can see that that left column in the gray, the raison d'annulation is the reasons for canceling. So one was a melanoma, one was a loss of withdrawal of consent, and one was a patient who passed away before a MAID. Otherwise, we've had, of the 2 donors, we've had 4 kidney transplants. The 74-year-old donor, that was a slightly older than we usually do for DCD in Quebec. But we accepted that based on the fact that the ischemic time was going to be so short, which is another thing that we've been talking with our transplant programs as to, how to, if at all, liberalize the eligibility criteria for this type of DCD. So prochaines étapes is next steps, and there are a lot of things to do. Standardized practice locally and nationally, but that standardization needs to be based on what happens and further information related to the development of these programs. And so we need to study the impact of the process, both on patients and for their loved ones. How can we ensure that we need to learn more. So, for example, I've mentioned several times that these patients are going to be dying at home, and we haven't done the qualitative or quantitative research to figure out is that a major deal for most of these families? How did they feel about having these increased monitoring at the time of death? Remember, even by saying increased, well, it's increased relative to our standard practice, but for an individual family, it's not increased relative to anything because it's the only case they're ever going to know. And how intrusive are these practices, and how much of an impact did it have on their experience? And trying to understand that is going to be important. We need to study the outcomes of organs recovered after MAID. We need to know, are they closer to NDD organs, which we know do a little better in terms of at least short-term outcomes? Are they closer to NDD or are they closer to DCD organs or somewhere in between? And what are the eligibility and exclusion criteria that we should be applying? And then we need to continue legal and ethical analysis of multiple issues, but including things such as death by donation and how that's going to fit into the ethical legal framework around this. So that's like I said, a quick overview. I think Karen, we can open it up to questions that I will try to answer to the best of my ability. Thank you for your attention.